Good evening and welcome back to the Rural Medicine Grand Rounds. I'm Dr. Lucy Ingram. Tonight's second case is a presentation of falls in the elderly in rural general practice. Discussing the case tonight, we have an expert panel consisting of Dr. Jim McConaughey, Rural GP, Dr. Nisal Gange, Geriatrician at Toowoomba General Hospital and St Vincent's Private Hospital. We have Doug Murtagh, a physiotherapist at Toowoomba Hospital, and Andy Mellis, Dr. Andy Mellis, Rural GP. Andy. Please welcome our specialist and expert panellists. As usual, we are being live streamed around Australia. We have a number of participants watching remotely, so I encourage you all to join the discussion by emailing your questions to grandrounds@qrme.org.au, or you can tweet your questions using the hashtag now on your screen. Our case tonight has been pre-recorded and will be played shortly, and that was from Dr. Nicole Cattanach from Toowoomba. Let's view the case now.
Hi, my name is Nicole Cattanach and I'm a GP registrar doing grand rounds today on falls in the elderly. My case today is Mrs. S, who is a 68-year-old female widow. She presents with recurrent falls. She states that she's had 3 in the last 6 months. On her first fall, Mrs. S said she was getting up for a chair to mobilise with her 4-wheel walker when she tripped and landed on her 4-wheel walker. She sustained a fracture of the 8th right rib and denied any pre-syncope symptoms during this fall. Her second fall, she was trying to get dressed when she got the shirt above her head. She states she lost her balance and fell again. She landed on her right side and, however, sustained no other injuries. This fall was, however, 2 weeks after her initial fall, where she fractured her right ribs, and because of the pain in this area, she was unable to get off the floor for many hours. Again, she denied any pre-syncope symptoms. Her third fall, she tripped over a mat at home. She felt that her leg did not pick up as well while she was mobilising. She sustained skin tears on her lower leg and did not go to hospital during this period of time. Mrs. S states that all her falls, she did not have any palpitations, dizziness, chest pain, shortness of breath or vertigo prior to the fall. She went to hospital for the first 2 falls, where she was treated as an outpatient. She did not have a CT brain during this time. She had a chest x-ray which found the rib fractures, but no other investigations. All falls were found to be mechanical in nature. On examination, Mrs. S is a thin lady. She weighs approximately 50 kilograms and has a BMI of 21. She mobilises with a 4-wheel walker and is unable to mobilise without this support. She has a blood pressure of 140/90 and does not have any postural drop. Her heart rate is approximately 70 beats per minute and is irregular. She has a systolic murmur which is loudest over the aortic region. Her chest is clear. On neuro examination, she has normal power, sensation and reflexes. She has a positive Romberg sign. Investigations that I've ordered include firstly an ECG, which shows that she's in atrial fibrillation with a rate of approximately 77 beats per minute. An echocardiogram, which her cardiologist ordered, showed she had severe aortic stenosis, an ejection fraction of approximately 60, and moderate pulmonary hypertension. Blood show a full blood count, a hemoglobin of 128, electrolytes being normal, liver functions being normal, with a creatinine of 90 and an eGFR of 44. Her TSH is 0.34. CT brain shows age-related changes but is otherwise essentially normal. From her past medical history, Mrs. S has hypertension. She has atrial fibrillation. As a young child, she was diagnosed with polycystic right kidney. She suffers from left-sided trigeminal neuralgia. Approximately 2 years ago, she had an axillary clearance for breast cancer with no primary cancer found. She also has severe aortic stenosis, hypothyroidism, hypercholesterolemia. Her medication lists include Atacand, 16 mg Mane, Alpha Press, 25 mg Nocte, Tonormin, 50 mg BD, Oroxene, 50 micrograms Mane, Lipitor, 10 mg Mane, Eplum, 200 mg Nocte, Pradaxa, 150 mg Mane. She has 2 mg of Valium Nocte if required, and Panadol Osteo, 2 tablets BD. Mrs. S denies any allergies. She lives alone, and as I said previously, she's a recent widow. She mobilises with a 4-wheel walker and is independent with her activities of daily living. She has a cleaner once a week and has ordered pre-cooked meals. She denies being a smoker or a drinker. My questions for the panellists today include: 1. What are the likely causes for Mrs. S's falls? 2. Are there any other investigations which I should perform? And finally, 3. What are the best management options for Mrs. S?
Great. That was a really interesting case. Again, if we can sort of open with sort of the general practice sort of viewpoint of that, I don't know if you want to tackle any of those particular questions, or if there were any sort of burning thoughts, Jim, that sort of come to you from hearing that case.
Yeah, I mean, her medication list looked unusual to me, but anyway, I can't remember exactly. Hydralazine doesn't act 24 hours, so I wonder why she's on it just at night. I can't remember all the other drugs, but I would look at those more closely. She's on atenolol twice a day. The echo sort of findings of ejection fraction 60%, but severe aortic stenosis surprises me, but yeah, I believe that one. Romberg positive, and it seems to be mechanical. Is it really Rombergism, or has she got a peripheral neuropathy? Is there something else happening there? She's got renal impairment, stage 3 by the looks of it. So there's a few things I'd look at there. Is the epilum, again, is that for the peripheral neuropathy, I take it? Not the trigeminal neuralgia, I imagine. Is that really needed, or is it working? Are there other more appropriate drugs? Living at home, her dressing, yeah, they're the medications. Pradaxa, again, she's on that for the AF, but then if we can't stop her falls, is that something we have to re-look at, the risk of that? And the diazepam, is there any association with when she has her diazepam to when she has her falls? I think has to be looked at. And how often is she really having it on a PRN basis? There's a few things there I'd like just clarified a bit.
Yeah, good. We've pulled up the medication list. I can see that you're nodding as well, Nisal. Sort of, how would you tidy up this one's medication list?
I agree with Jim on almost everything he said. And now you often get a history of these mechanical falls. And how often you and I do not have mechanical falls, and why would an older person would have a mechanical fall? In my books, there isn't no entity called mechanical falls or as same as there's no social admission, there can't be any mechanical falls either. There has to be some pathological process that's going on in an elderly person for someone to fall. Now, the first question I would have is, although there are no pre-syncopial, in a person who's in an elderly person, how much that history would be reliable? So the first question is whether she is still having hypoperfusion changes from her atrial fibrillation, or whether she's having tachy or bradyarrhythmias from her atrial fibrillation, or if this aortic stenosis is worsening, that's causing the fall. And that might, often these patients come and say, still, I tripped and fell over. So you need to look at that. Looking at this medication chart, now basically if someone has, if you have aortic stenosis, centrally acting drug or a ACE inhibitor or angiotensin 2 medication is contraindicated, and basically I'll be looking into probably taking her off from candesartan. I can't recall what her blood pressure was, and
140 on 90.
140 on 90. So that's a bit, it's again a bit surprising that with that tight stenosis, with her being on all these medication, for her to have that high blood pressure. At this point of time, that's very important. As we get older, with all the comorbidities, trying to manage someone's blood pressure, micromanage to have it around 130, 120 might not be in that person's best interest. In this patient, I would probably take some of these antihypertensives out and probably accept a blood pressure of 160 is not a bad blood pressure for her with aortic stenosis. I'd be really worried if she comes with a blood pressure of 110 or 115, on the other hand, because there isn't much. She only needs to be a bit dehydrated for her to fall over. Now, I don't see here a calcium channel blocker, like something like amlodipine, which might not be a bad idea. Again, atenolol, some say if you have a dose more than 50 milligrams, maybe it's not adding much to the management, especially in the elderly. So I usually don't go above 50 milligrams, and certainly, as Jim mentioned, I would try to get this down to once a day. Take Atacand out. Alpha-press, again, hydrolysine for a person who's have got severe aortic stenosis might not be a good option either. So 3 medications can be taken off, and probably might need to add, if I weren't to add, I would add probably amlodipine onto that. Epilim, in the longer run, would have Parkinsonism type of features. Now, this lady, for the 3rd time, she did not clear her leg. So I'll be doing a full neurological examination to find out whether she's got any Parkinsonism features, because there are some medications that can, epilim in the longer run, can give rise to that kind of a medication. Valium, probably take it out immediately, because there are other medications that can be given if that's needed. Benzodiazepine, Valium, diazepam especially. As we get older, our fat content in the body increases, and Valium diazepam is a fat-soluble benzodiazepine. So if you give maybe more than expected dose for Valium to an elderly person, that stays in their body for a much longer period. So again, if you were ever to think of a benzodiazepine for an elderly person, I would always think of a short-acting drug. Something like oxazepam would be the one I would be choosing. Pradaxa is a interesting phenomenon. There was a study done on falling people on anticoagulation in elderly. For a person to counteract the benefit of anticoagulation from preventing strokes, you need to have 297 falls per year before you would consider that is harmful for that patient. And I've been a bit biased because I look after the stroke unit here in Toowoomba, and I see, if I had 4 patients, severe strokes on my acute unit, 3 of those patients were patients for a number of reasons taken off from the anticoagulation coming in with a severe stroke as such. We don't have a crystal ball to say, but I would think this lady would be much more much more adversely affected taking her Pradaxa off than leaving her on it unless she has everyday falls. So that's what I think I would be looking into. It's just, although she has aortic stenosis, there can be other reasons. So good neurological examination, as Jim said, peripheral neuropathy ruling it out, Parkinsonism, rationalizing the medication would be the first thing I would be doing. Yeah, thank you.
And just sort of interesting on that point of the sort of weighing up the stroke prevention and the intracranial bleeding sort of risk with your NOACs, as they call them, novel oral anticoagulation. Just getting sort of the GP perspective, I mean, we tend to use for the registrars, or we're training them to use, your HAS-bled versus your CHADS-VASC to scores and sort of utilising them. How does that play out? And for yourself, you probably more come from the experience perspective, but do you use the HAS-bled sort of much, or is that good for registrars to be using?
The HAS-bled is interestingly is being validated for warfarin and is not for any of the novel anticoagulants. And if you take the three novel anticoagulants, consistently the three anticoagulants have shown when it comes to intracranial bleeds, they have a better track record than warfarin. But when it comes to GI bleeds, bleeding into the gut, Pradaxa has a much higher incidence of GI bleeds compared to warfarin. Same with rivaroxaban. But when you take epexiban, the novel anticoagulant, it has lesser brain hemorrhage as well as systemic hemorrhage as compared to warfarin. Now, regarding falls, if this lady came to us having had a fall and had a subdural, I would be a very brave person to start her back on novel anticoagulants. Unless that person has shown a significant catastrophic bleed from that fall, or else these falls are happening, I think 297 is an over-exaggeration. And let's say, unless she falls every week, I would be reluctant to take off. HAS-bled, yes, I use that when patients is putting me on spot to give me a number. But most of the time, you could probably think of the risk factors. The main risk factors with the bleed I take is if they had a previous intracranial bleed or a GI bleed, I'll be hesitant. Anything else, I will be very keen to put them on. But having said that, I'm a bit biased here because I take all the patients who have had complications of not being on anticoagulation. Yeah.
And from experience, Jim, what do you think is the new novel oral anticoagulants as compared to warfarin, particularly in this sort of older age group? High falls risk.
I guess I don't know the figures on it, but the patients love them, and they're not having the frequent INRs and frequent changes in dosage. I've had a couple of issues with them where I've had one lady with a subdural, but she hadn't been on warfarin prior to that either, so whether I can't predict, I can't compare the two, just from a patient's liking of them. They seem fine. So as drug interactions with other drugs and stuff like that, they seem better profiled.
Andy, if I can cross to you.
I would agree with that. They're very popular with patients. So I'd agree with what Jim said.
The rule of the thumb is always use the highest dose you could. Just because you like one drug doesn't mean that you need to go to the half dose. For instance, with Pradaxa, you got 150 milligrams twice a day and 110 milligrams twice a day. Then with Eliquis or Epexiban, you got 5 milligrams twice a day and 2.5 milligrams twice a day. If you can't give Pradaxa full dose, rather than going to the half dose of Pradaxa, you have to think of other drugs, whether I can give the full dose of Epexiban. Simple example is the age. If you are above the age of 75, you cannot give the full dose of Pradaxa. And then you need to bring that down to 2.5. Rather than doing that, I would 110 milligrams twice a day. rather than doing that, I would always change that to apexaban, which is the highest dose. So in other words, if anyone comes at the age of above 75 needing anticoagulation, I think there's enough of evidence for us to say apexaban 5 milligrams, as long as their renal functions and the body weight allows them, that might be the way to go.
And what about in this lady with her, a polycystic kidney since childhood, and EGFR 44? I think the creatinine didn't look too bad. Still sort of reasonable?
So given the creatinine less than 50, you can't have the Pradaxa full dose. So she's on the correct dose of 110 milligrams. And I can't recall what her age was. I
think it was 86. She was introduced to 68, but I think she was 86.
86. Again, given the age of 86, even if her renal functions were better, she would have still not had the full dose of Pradaxa. So this is an ideal case. If I were to start on this lady, I would have started on apexaban full dose, because apexaban, just a marginally renal impairment, is not a contraindication to give the full dose as such. She had it for such a long time, and if she had bled it, then she would have bled by now. And her risk of bleeding into that polycystic is much smaller compared to her risk of having a stroke if she's not on anticoagulation. Yeah.
All right. And you just sort of, something that sort of you brought up before is sort of looking for some Parkinsonism symptoms. We might just sort of flick over now to our physiotherapist, if that's all right, and sort of maybe looking at that aspect, and then maybe just talking more broadly about this case and your approach. So this lady had been referred to you, recurrent falls.
Sure, yeah, and it's something we see a lot. So, and I agree with Nisal in that I see this as a starting point in the assessment, but there needs to be a lot of investigation in terms of her physical function. So looking at passive range of movement, strength, how she actually puts that together in terms of coordination, her actual mobility as well. So is it symmetrical? Is there an asymmetry? In terms of how she mobilises behaviourally as well. So is there, in terms of her concentration, and is she move with hurried movements, which a couple of the falls might indicate there's a lack of precaution. Going back from that, I think it's important too to look at the longer history. So generally I would look at 12-month period of falls and try and get an idea. So in this situation, is this lady, has she been, in terms of her mobility, has she had no falls for, say, years, and then suddenly she started having falls, or is this a reasonably consistent pattern for her? Also, in terms of her mobility, is this a big change? Is she someone who obviously lives alone? So does she normally mobilise to the community, into town, high-level mobility? And is this a real deterioration, or is it not that different to her normal? So I think that's really important to ascertain. Two, probably the one little flag there is the recent death of her husband. So whether that's had an impact on her, it might have impacted on her mood, it might be impacting on her nutrition. So her BMI is fairly low anyway. So that could be a factor. I'd like to know when the falls actually happen. So in terms of that history, are they happening later in the day, for example, maybe when she's fatigued? So that would be something to consider. So is there a pattern there? In terms of the Parkinsonism, potentially that would come through in your assessment. So you'd be looking at passive range of movement and tone. That would give you a good start on that anyway. And then just looking at her movement patterns. You would think that probably would have identified at some point earlier, before she started having the falls, and that she may have had tremor or other difficulties rather than the falls as the sort of the initial presentation with that. There are other things too. So, I think basically it's easy for me because I get an hour basically to go and assess people and work out what's going on. I appreciate someone coming into a GP practice. You don't have that luxury. So, and that's where allied health are particularly good at, I guess, going through that. Home assessment as well could be an important factor to consider. So how is the home set up? What are the supports like?
How accessible is that in terms of allied health home assessments, particularly in rural areas?
My guess is not very accessible without, basically I'm in Toowoomba, so I will go 30 minutes from Toowoomba, and that's about as far as I'm allowed to go. So yes, if you lived, Crow's Nest or wherever, you're going to be issues in terms of that accessibility, particularly if there's a rapid response needed. So if someone started having falls and their mobility is borderline safe, I imagine once you get out of Toowoomba, you're going to have much more limited access to that allied health input.
What about sort of costing and MBS rebates and things? Is there much sort of available for physios?
I'm really very unaware of that. So working in the public system is not something I'm really aware of. So if you're DVA, you can get reasonable access depending on the availability of the actual therapist. But I think my understanding is in the rural settings there's actually not, there might be funding, but it's actually having the therapist there available to go and see the patients as well. So even if you were DVA, having someone to come in that short time frame could be a big issue. Yeah.
EPC items, gentlemen, what do you think about this patient?
Our practice nurse does home reviews of patients. You can do those on a Medicare item number. Sometimes you can cheat and even get pharmacists to do home medicine reviews, and they'll often comment on their living arrangements as well. They're not a physio or an occupational therapist, but you can cheat the system a little bit sometimes. But there are Medicare item provision for home visits, and we ourselves.
In the rural area, there is a program managed through previously the Medicare locals and now the primary healthcare networks with a long-winded acronym that I always struggle to remember, but it's basically to facilitate rural allied health services, and that's a nationally run program that specifically will target allied health into rural communities. So if people were to look on their region's primary health network website, they would be able to access that information about accessing allied health into rural communities. And I know certainly within the Darling Downs region that is available in rural areas.
What about aged care assessment teams for this lady?
Yeah, aged care assessment teams. There's a lot of reassurance has to go that way. Once they hear of aged care assessment teams, a lot of people just associate you're pushing me into a nursing home automatically. So there has to be that reassurance that it doesn't mean that, but that most people you can explain to them, look, you're at an age where things can happen suddenly. Just because you're assessed doesn't mean you have to do anything, but if something happens and you have never been assessed, then there are longer delays, and most people you can get around that way. But there are the aged care assessment team. I think that's changed recently with the federal budget, and I'm unaware of the full budgetary changes though. Andy, are you familiar with them?
It's more that the home and community care component has ceased, so what used to be HAC has now been taken over by the My Aged Care service, which is
with the website.
A website which details beautifully all that's available, but of course there's not too many elderly patients who are internet literate and resourced to go and access this, so often the limited experience I've had so far is it's often meant that the family members are the one now doing the legwork, because it's all about patients having control of their resources and patient initiated, which sounds great, but it now puts the onus on the patient or the family to do all of the legwork to decide on how they wish to spend their resources. So the family member or the patient is now ringing up a 1-800 number to talk to a My Aged Care caseworker to start that process.
Interesting.
And I believe, although I may be wrong and Nisal may know more, but I believe that ACAT is intended to go that way as well.
Have you heard anything in that space? Or?
Look, I think it's an evolving process at the moment, and funny enough, for the team who was spanning it out for Darling Downs, and both me and Doug went for that meeting as well. They themselves were not sure about the process because it was changing every week as such. And I agree with what Andy says. It's a more confusing process, but I'm sure looking at a positive way, I think these will be ironed out and made much more user-friendly. Because even as the clinicians, we are struggling at this moment of time because the care packages are now being categorized in a different way, which is different to how it used to be. And I can just imagine how the elderly person would be in the middle of all that. But hopefully that will be resolved. That's what my understanding is.
So we can come back to sort of the questions that Nicole had asked sort of with this case. I mean, I know there's a lot of missing information there, but what would be your feeling as to the cause of this patient's falls? Do you think it's predominantly medication related?
No, as with most of the falls, in an elderly person, if falls more than 80% of the time, is more than one cause contributing to it. I think in this case, is again a fine example. I believe it's a combination of factors. At least from the history, it is repeatedly said that it's not pre-syncopal, but I would still not rule that possibility out. Medication might be a polypharmacy is an issue with this lady, and so I'll be trying to rationalize that. Do a proper neurological examination to rule out, with the help of a person like Doug, and the clinicians, to rule out diseases like Parkinson's disease, peripheral neuropathy. The other ones is the balance organ, and again I look at Doug because he runs our Vestibular clinic in Toowoomba Base Hospital, and to find out whether there is a problem with the vestibular system as such. And
can I ask a little bit more about that service, if that's all right? So can you tell us a little bit more, Doug, about the Vestibular clinic?
Yeah, so it's an outpatient clinic that we have. It's for people with vestibular dysfunction, not always causing falls, but a lot of the time that people are having falls as well. So there's a reasonably strong link there. It's a new service. So probably 3 years ago, there wasn't as much recognition of the vestibular system in terms of physiotherapy being able to manage that and even to assess that and identify some deficits. So it's a reasonably new service, but it's amazing how much it's there when you look for it in terms of that vestibular impairment causing problems with balance and mobility. So probably of relevance to GPs in the rural setting is the actually identification of those patients. And I agree with Nisal in that I wouldn't rely just on this lady not reporting that there was no dizziness. Okay, I think it's not always that simple. So what people call dizziness can vary quite a lot. And also people with vestibular impairment sometimes don't even recognise dizziness or vertigo as such. They'll talk more about imbalance or a sense of imbalance. So that can be the presentation in terms of the symptoms that they're reporting. We use a screening tool, so there's a simple screening tool that's been identified or been developed. 4 questions scored 0, 1 or 2, as in yes, no sometimes, and based on that score they then get linked in with outpatient physiotherapy.
And what kind of things do you work on with them?
So it's identifying the cause of the vestibular impairment. So the most common things are the BPPV, so peripheral cause. You can also, quite common is a neuritis. We also need to screen out something more central, so potentially a stroke or even MS. It's reasonably common to come across Meniere's disease, migrainous vertigo, other common presentations. So in our assessment we can distinguish those reasonably well. Some are less easily identified than others, so the migrainous vertigo and the Meniere's tend to be a bit harder. And based on that we have, there's retraining. So in terms of the vestibular ocular reflex, we can retrain that with some very simple exercises over 3 or 4 weeks. That generally has good effects in reducing those symptoms. The BPPV is generally pretty well treated, so highly successful with that in terms of the repositioning manoeuvres that we can do.
Brandt-Daroff or something like that?
More Epley.
Epley's,
Yeah. But Brandt-Daroff